This is a 8-year-old child with post-traumatic total membranous cataract with a fibrosed and calcified anterior capsule. So I planned for lens aspiration with PCIOL implantation. First, main port and side ports are made, air and dye injected, proper staining is ensured since the capsule is calcified and glow is not visible. CCC was started with capsulotomy needle and microforceps used to complete the rhexis. Since the capsule was fibrosed, so I planned the rhexis circle to go beyond the fibrosed area. Then gentle hydro and visco dissection done to separate and lift the peripheral hard cortex. Now a second layer of fibrosed capsule was noted and lifted with forceps and peeled. Then scissors was used to cut and separate the dense attachments of anterior capsule with the plaque and rhexis was completed. Visco is used to separate the plaque from the cortex. First I tried with bimanual IA, but the lens matter was very hard and fibrosed. So I used forceps to separate and lift the peripheral cortex from the capsular bag. Then I used phaco probe at low settings to remove the peripheral hard cortex. Then glow was visible and dense plaque was seen attached to the PC. So first I removed the peripheral cortical fibers with IA probe. Then I injected visco alongside the plaque and tried to peel it with a dialer, but the PC was getting distorted and there was a risk of PC tear. So I used micro scissors to cut the plaque along with the PC and block as a mass all round. But one part was left attached and held with forceps. And first I did anterior vitrectomy below the plaque to remove any attached vitreous before pulling the plaque to avoid any vitreous traction. Then anterior vitrectomy was done. Sulcus was formed with viscoelastic. A circular PC defect was seen with an irregular anterior capsulorhexis and a 3-piece IOL was placed in sulcus. With haptics rotated over the area of maximum anterior capsular rim. Pilocarpine was injected. Main port was sutured. Visco aspiration and anterior vitrectomy was completed. Air bubble was injected to make sure there is no vitreous in AC and round pupil was achieved. So take home points include always stain the capsule in a white cataract, use microforceps and scissors for anterior capsulorhexis in case of a fibrosed capsule. If there is a thick central plaque, then always remove the peripheral cortical matter first and keep the central plaque for the last. Then try to peel the plaque gently and use visco dissection. If densely attached to the PC, then cut at the margins with scissors to create a circular PCC, but keeping one unattached. It is important to do anterior vitrectomy below the plaque before pulling the plaque to avoid any vitreous traction. Always keep a 3-piece IOL on standby in all these type of cases. Thank you.